Okay, welcome to today's training, Maximizing Micronutrients. Today is Wednesday, April 24th, 2024. Next slide, please. Okay, this training is hosted by the Ohio chapter of the American Academy of Pediatrics under the Parenting at Mealtime and Playtime program. In its 20th year of funding, Parenting at Mealtime and Playtime has provided evidence-based education to physicians, nurses, home visitors, community health workers, and beyond. Tackling a myriad of topics, this year, PMP will discuss breastfeeding, creative ways to bolster nutrition, and how to navigate difficult weight-related conversations. The presenters today, Divya Dendulori and Kylie Yike, have no relevant disclosures. Next slide, please. PMP handouts can be found on the Ohio AAP website, linked through this QR code. The handouts are designed for caregiver and child use and provide information on various topics. Next slide, please. The PMP Toolkit has been designed with physicians in mind and is linked here. The toolkit has resources on how to increase your practice's presence on social media and common EMR phrases to use when working with a pediatric population. Next slide, please. The PMP website has recorded trainings on supportive clinical spaces and engagement with patients living in larger bodies and motivational interviewing. The Ohio AAP is excited to continue the work of PMP and looks forward to diversifying its audience and topics. If you have any ideas for the toolkit or mobile app throughout today's session, please share your ideas in the chat or reach out to me, Sahavi, the PMP Program Manager. We always appreciate feedback from our learners. With that, today's training is hosted by Divya Dendulori and Kylie Yike. They invite your feedback on their presentation and have considered the Ohio AAP's DEI standards. Divya works at the Dayton Children's Pediatric Clinic as an outpatient dietitian and as an inpatient lactation specialist. She enjoys working with parents and babies and supporting them on their unique journey of nourishing their babies. Kylie Yike is a clinical dietitian at Dayton Children's Hospital. She provides outpatient nutrition counseling for children and families with a multitude of needs, but specifically enjoys working with picky eaters. Kylie also works with premature infants and children of all ages with developmental delays. Thank you so much, Divya and Kylie, for being here today. I will pass it off to you.
Great, thank you so much. All right, so we'll go ahead and get started. Divya and I will be presenting individually throughout the presentation, so we'll be changing our camera when each person is up. But I am Kylie. I'm going to start out our presentation. Here's our learning objectives. You can see what we're going to be discussing today, talking about why are micronutrients important, what are some common micronutrient deficiencies in children, talk about recommended intake for specific micronutrient concerns, discuss risk factors and potential clinical manifestations of micronutrient deficiencies. And excuse me, I am going to mute for just a second. I apologize. There we go. Okay. We're going to illustrate how to identify potential micronutrient deficiencies, we're going to connect food sources and interventions to prevent or correct micronutrient deficiencies. So I think the first step in sort of thinking about why are we doing this? Why are we looking at micronutrients? Why are they important? And I think the most important thing is that we know that our calories and our protein help children to grow, but it's so much more than that. Our vitamins and our minerals play a substantial role in all areas of growth, development, and function within the child's body. And so it's really important to keep in mind that we're not solely focused on the calories that are coming in, but the nutritional quality and the variety of the micronutrients as well. And we also know that micronutrient deficiencies can cause some other medical complications. So, for example, vitamin C deficiency, also known as scurvy, we can see children might have really sore, red, or bleeding gums. And so in order to correct that medical condition, we would want to address the micronutrient deficiency. But it is really challenging to assess for micronutrient deficiencies. We live out in the world where there's so many factors that impact how we eat. And, so it's really hard to get a really close, detailed look at what foods we're eating, how much, and what kind of micronutrients they provide. If we were, let's say, in a specialized study where we were kept in a room and we were provided exact foods and we had the exact micronutrients of foods and could say the exact amount of foods we'd eat, sure, we might be able to be really precise about the micronutrients we're consuming, but that's just not the case for our day-to-day life. So, so what do we do when we know that it's challenging? As dietitians, we have a lot of means for assessing the nutritional intake for a child. I listed a few up here: multi-day food diaries, 24-hour diet recall, food frequency questionnaires, typical intake. Pros and cons for all of these. So a multiple day food diary, what that entails is that we ask the families of the child we're meeting with to write down exactly what the child is eating over a period of 3 to 5, maybe sometimes 7 days, sometimes longer, to really get a good sense of what that child is eating. And they can be really great resources. If we get really good information, we can use that to do a much deeper dive into the micronutrients that child's consuming. But the challenge is it's really time consuming, and, parents or caregivers can be very busy, or, I offered my child this meal, but they only ate some of it. So trying to guess about how much they ate, it's hard to remember. It's hard to remember to write the brands down. So even the best of efforts, this can be a really challenging ask. 24-hour diet recall is very similar to the food diary. You're just asking the family, what did the child eat over the past 24 hours, or what did they eat yesterday? Again, really gives us a good snapshot of an actual day. But, the downside is it's just one day, so it may not reflect what typical intake is. Food frequency questionnaires are great because it can give you a general idea of how many servings of each food group on average someone might eat in a day. But, they don't tell you, it is not as clear or conclusive on how the day-to-day looks for that child. And oftentimes people can maybe overinflate or underrepresent what they're actually eating. And we also find that too, sometimes going back to that multiple day food diary, that the family may be writing down what they think the dietitian wants to hear, not what actually is happening. So they might be modifying their eating habits in anticipation of this appointment. Or we can talk about typical intake. So what do you normally eat for breakfast? What do you normally have for a snack? And get a general idea of common foods that are eaten at that meal. So for us as dietitians, when we meet with our patients, a really good starting point typically is getting a 24-hour diet recall right away, and then using that as a basis to say, okay, is that your typical intake? If not, can you tell me what meal might differ and why? And then we may resort to the multiple day food diary if we need some more in-depth information. As I said before, there's tons and tons of factors that can impact what a child is eating, thus impact the micronutrients that they're consuming. We know that social media and peer pressure and honestly too, even for parents or caregivers, influence that they might see, what's popular or trendy right now, can really impact food choices. Also things like, financial limitations, transportation limitations, the location of grocery stores or other stores that provide food, and what kind of nutritional quality of the foods that they sell within those locations. What's the meal environment like? Is, our nutritionally dense foods being modeled by the caregivers at home at family meals, or are we eating out more frequently? So there's many, many things to go into it. So, when you think about doing assessment, yes, it's really great. Even getting a multi-week food diary from a family is wonderful, but we have to take a step back and look at those broader strokes of what else might be impacting those food choices so that I can give recommendations that fit for that family and aren't so textbook. So typically when we are obtaining a 24-hour recall, or we're talking about what typical intake might be, we're usually starting with more generic questions and then narrowing down depending on things that might catch our attention. And oftentimes we've got this My Plate, which is modeled off of the Dietary Guidelines for Americans, in the back of our mind as we're asking our questions. So it might be something like, okay, you told me that you had Frosted Flakes and a banana for breakfast. Did you have milk with your cereal? No? Okay. Do you have milk any other time of day? And so I've kind of started with what they told me. I looked at, I don't hear a dairy here. Let me ask some more questions about that. So it helps us narrow in and get some more information. And then again, if we've asked a lot of those questions, we've really narrowed down, and there's just some more lingering concern, coming back to that multiple day food diary, and then putting it into a program that does really strict nutritional analysis might reveal some things that we didn't otherwise identify through our questions in our appointment. I wanted to throw in a few slides here just about the dietary guidelines for Americans. I encourage everybody to, take a look at them if you haven't already, have them maybe as a reference saved for you. It's a really great document. And actually, we're getting ready to see new dietary guidelines coming out here soon. Our current ones are for 2020 through 2025, so they're actively working on the update for the next 5 years. But it talks about recommended dietary intake across all ages for Americans, and also really talks about health concerns and nutrition concerns within the typical American diet, and what are some action points that you can take to address those concerns. And specifically, I really liked this picture because this is targeting, our child and adolescent age group, and it's showing you kind of the quality of the foods that a typical American child or adolescent would consume. So what we're looking at here is the Healthy Eating Index score is a score given to somebody based upon the nutritional quality of the foods that they eat. How closely are they matching the dietary guidelines for Americans? And it's a score from 0 to 100. And so you could see, the highest score is 61 for those in the 2 to 4-year-old range, and only goes down from there. So what that's really telling me is that any patient that I might be meeting with, I know this is an average, but across the board, our average, adolescents are likely not meeting the micronutrient needs they need, and the nutritional quality of their diet could use some improvement. Some other contributing eating patterns that we really have to take into consideration when we're thinking about eating habits and are we meeting all the micronutrient needs. I'm not going to read through all of these, but I just wanted to pick out a few. That first one, too much milk or not enough milk. It's a big one that we see often. We know that milk is a really good source of calcium and vitamin D to help with bone health. So if we have a child that doesn't drink enough milk and also doesn't consume other dairy-based foods, we might have some concerns for insufficient calcium or vitamin D intake. Alternatively, children who drink too much milk, a lot of times families might think, well, they drink a lot of milk, and I know milk is good for you, and it absolutely is. But we know that calcium and iron compete for absorption. So if you have a diet that's really high in milk, are we potentially putting that child at risk of not absorbing as much of the iron in their diet as they could because of that excessive amount of milk intake? And the other thing that we see with too much milk intake, and also too with that second point, maybe too much juice intake, is that child filling up on those beverages, so much so that they're not eating a sufficient quantity at their meals. And so unintentionally, we're lacking nutritional quality, nutritional variety in the calories that we consume because it's being taken up primarily by the beverages that we're drinking. So then that puts you at risk of, a multitude of micronutrient deficiencies. Again, some more contributing eating patterns. I think it's also really important to think about any sort of medical condition or acute illness, chronic illness that the family might be facing. So some things might be, was the child, and I know some of these aren't listed up here, but, did the child have a recent hospital admission? Did they have a recent surgery? Do they have any burns or wounds that they might be healing from? Those might contribute to increased micronutrient needs through that healing process. We also know that in the acute care setting, there's quite a multitude of micronutrient needs specific to the disease state that we're managing. That's a little bit outside of what we're going to talk about today, but it's always important to keep in mind that's something we look at in the inpatient setting as well. And then some other things such as, if the child has difficulty chewing or difficulty swallowing, we might have to modify the textures of the foods they consume. And in doing so, do we then miss some important food groups or specific foods with micronutrients that are necessary for that child's diet? To give you an example, I work with children that often might be limited to pureed foods, and we can definitely provide a well-balanced diet in pureed foods. But a majority of the time I will see families will purchase pre-made baby foods at the store. And yes, their child is getting the calories they need, but maybe we should focus on pureeing up meals at home, or at least doing a combination of some of that so that we're getting micronutrients from other places, not just from the commercial baby foods available. Allergies or sensitivities, that could lead to eliminating full food groups or a majority of foods within a food group. So then again, we're at that risk of, we have to eliminate these foods for a medical reason, but is there a risk of there being a micronutrient deficiency because of that? One last thing that we always keep in mind when we're doing our assessment with a patient, trying to determine, is there a micronutrient deficiency present, is doing a physical exam. So dietitians are trained in a complete nutrition-focused physical exam that includes, does the child have adequate muscle stores? Does the child have adequate fat stores? And then we're also looking at particular areas on the body where there might be a potential indication of a micronutrient deficiency. And so I just wanted to show you this to you guys today. This is a booklet that all of us here at Dayton Children's have, and it's a really nice source for our physical exam. And they have some really nice pages in there about just what I have listed up here on the slides, how to identify, is there a potential micronutrient deficiency? So we keep that with us at all times. And, once you get practiced at the physical exam, we find it's pretty quick and easy to run through all the areas very easily. And you can see here, like I said, for teeth, that can be an indication of a vitamin C deficiency. If we're noticing some changes to the child's tongue, it's really excessively red, really sore, really swollen. That can be a multitude of B vitamin deficiencies. So lots of different micronutrient deficiencies that are possible, and we're always looking for that. One thing that we have to keep in mind is that, some of these presentations could also be related to other things. So, maybe that child just has poor brushing habits and just poor dentation because of that, and not necessarily that they have a vitamin C deficiency, but that's why we're seeing some issues with their teeth. So it's always important to keep all of these factors in mind when we're doing our assessment to assess for micronutrient deficiencies. So what we're going to go into next is talking about some specific micronutrients that we most commonly see in our patients, specific here to Dayton Children's, While I wish we could go through every vitamin and every mineral and talk about what foods are high in those, we really try to focus in on some that are particularly important for the patients that we work with. So with that being said, I'm going to turn it over to Divya.
Thank you, Kylie. Hi, everyone. I'm Divya, and I will be talking a little bit about a few of the micronutrients that we thought were important to address today. Just give me a few seconds. I'm so sorry. All right. So the three important micronutrients we're going to talk about are iron, vitamin D, and calcium today, and starting with iron. So iron is an essential micronutrient for growth and development, and it is part of many proteins and enzymes that are required for growth and development. In the body, including hemoglobin, which is found in red blood cells. It's also stored as ferritin, or hemosiderin in the liver, spleen, and bone marrow, and in muscle as myoglobin. Typically, a low hemoglobin or hematocrit value is used as a screening tool for identifying patients with anemia. However, these tests may not be as sensitive to low iron status prior to the development of anemia and may not be adequate screening measures for all populations. So iron studies may include serum iron level, total iron binding capacity, transferrin, serum ferritin, transferrin saturation, to allow for more specific diagnosis of iron deficiency. And some signs of, I guess I went ahead, sorry, yes. Some signs of iron deficiency may include fatigue, weakness, pallor, tachycardia, palpitations, sensitivity to cold, shortness of breath, altered learning, loss of appetite, spoon-shaped nails, and like paleness in the lower eyelids. Some risk factors for iron deficiency anemia are typically a lot of times it's because of inadequate iron intake, and it can vary depending on the age of the child. Full-term infants are typically considered to have adequate stores of iron, and infants and young children from 6 months to 4 years of age are at high risk because of rapid growth rates and insufficient body reserves beyond that of 6 months. Iron absorption may be decreased, and there may be increased losses of iron with diarrhea, and children with feeding or swallowing problems may find it hard to chew certain meats and other high iron foods. Also, picky eating and restrictive eating, excessive cow milk intake, food insecurity can contribute to low iron levels. Conditions such as hemorrhage, renal disease, and decreased gastrointestinal transit time can also increase the risk. And at-risk individuals may need to be screened for iron deficiency. So iron stores are difficult to assess in infants younger than 6 months of age, as stores are typically used for growth and iron parameters are in flux during this time. The dietary reference intakes, or the DRIs, assume that the infant has accrued adequate stores before birth to last 4 to 6 months of age. And universal screening is typically recommended at approximately 1 year of age. Selective screening may be performed at any age when risk factors for iron deficiency are identified. Typically, the body absorbs more iron from foods when iron stores are low and will absorb less when iron stores are sufficient. An iron-rich food intake pattern is recommended for children at risk for iron deficiency. And iron in food exists in two forms, heme and non-heme. And heme iron is absorbed more efficiently than non-heme iron. Heme iron comes from animal sources such as meats, including oysters, liver, lean red meat, poultry, tuna, and salmon. And non-heme iron comes from plant sources such as whole grains, soybeans, lima beans, dried beans, like kidney beans and navy beans, nuts, dried fruits, and greens. A few ways to improve iron absorption are to eat heme iron and plant-based iron sources together. For example, maybe pork cooked with a sauce of dried cranberries, or a burrito that contains both beef and beans. Another way is to add foods high in vitamin C at the same time as iron-rich foods, such as beef and broccoli at the same meal. Cooking in cast iron or stainless steel cookware may increase the amount of bioavailable iron in foods as well. All right. Iron deficiency is usually treated with an iron-rich diet, and sometimes supplementation may also be needed. Some suggestions are to include maybe one iron-rich food along with a food that promotes the absorption of iron at most meals and snacks. Also, maybe introducing iron-rich foods at 4 to 6 months of age for most infants is also helpful to replenish those stores. And then iron absorption truly varies. If it's from a supplement, it can vary based on what form of iron it is. Most supplements typically are provide non-heme iron, and then so their absorption can be enhanced by having them with vitamin C, with the vitamin C rich food or drink. And then iron absorption from supplements are typically highest in an empty stomach. So sometimes even divided doses between meals can optimize that absorption. Some foods that hinder iron absorption are tannins from tea and coffee, oxalic acids that are found in spinach, chocolate, berries, phytates that are found in whole grains, bran, legumes, and other high fiber foods, calcium-rich foods, including milk. And so it may be helpful to serve these foods separately from meals that have iron-rich foods. That way we maximize the iron from the iron-rich foods. All right. Coming to vitamin D. Vitamin D is another important micronutrient. It is important for optimal bone health and for the prevention of osteomalacia, or the softening of bones, and rickets. It also protects against autoimmune disorders such as autoimmune disorders, and also acts as a hormone in the body and has many other functions. Vitamin D also has a unique metabolism and is produced in the skin when exposed to UV or ultraviolet B radiation and sunlight. So that kind of becomes that active form of vitamin D, which is vitamin D3. Vitamin D can be produced through exposure to sunlight and also can be consumed through dietary sources, although the sources are pretty limited. So one study estimated that 80% of the vitamin D supply comes from that UVB induced production of vitamin D, and about 20% from dietary intake. But this varies considerably depending on factors such as the season, sun exposure habits, location, nutrition, and then supplement intake and ethnicity as well. So who are at risk for low vitamin D levels? Vitamin D is deposited in the adipose tissue, which is not readily available to the body. So sometimes, especially in obese individuals, it may be that we need to provide larger doses of vitamin D supplements to achieve a good level of serum vitamin D. So in support of the hypothesis that vitamin D is stored in adipose tissue, weight reduction studies show that serum vitamin D levels rise when obese individuals lose body fat. Individuals with darker pigmented skin have a decreased ability to synthesize vitamin D, and then people living in more northern states may have less exposure to sun. And then also the use of sunscreen, which is recommended to reduce the risk of skin cancer, can decrease that ability of the skin to synthesize vitamin D. Breast milk is typically is awesome, and that's what we recommend, but it also does not provide adequate vitamin D. So we also we recommend vitamin D supplementation for all breastfed infants until the age of 1. And for premature infants, their nutritional needs are high, including vitamin D and calcium. This is for catch-up growth, for bone mineralization. So that's also another population that may be at risk for low vitamin D. Dairy is a primary source of vitamin D, especially in toddlers, and a diet restricting dairy and other foods that are high in vitamin D requires alternate interventions. And then patients with chronic hospital stays, patients on anti-epileptic drugs such as Dilantin, phenobarbital, with maybe long-term corticosteroid use, patients with malabsorptive disorders, small intestinal bacterial overgrowth, and autoimmune conditions are also at risk for low vitamin D levels. Right. So this slide lists the RDA for vitamin D by age, which remains the same from ages 1 year onwards. Maternal vitamin D status influences the vitamin D status of an infant. So without supplementation, an infant born to a mother with vitamin D deficiency can become vitamin D deficient sooner than maybe an infant born to a mother with adequate vitamin D status. So it is estimated that 20 to 37% of infants in the United States meet the recommendation for vitamin D intake. So the recommendation that infants receive 400 international units of vitamin D from birth takes an additional importance, considering the high frequency of vitamin D insufficiency reported in pregnant women and breastfed infants. So this slide reviews food sources for vitamin D. Vitamin D from foods are primarily animal in origin unless the foods are fortified with vitamin D. Dietary intake of vitamin D from natural foods plays only a minor role with few available natural sources. So some sources are fatty fish, cod liver oil, and egg yolks. So you can see how it is maybe, it's difficult to get adequate vitamin D for some individuals with just the diet alone. So foods can be enriched with vitamin D via fortification, and good food sources of vitamin D fortified foods are beverages such as milk, fortified soy and nut milks or beverages, fortified juices, yogurt, cereal, and margarine and certain spreads. So in terms of how do we prevent low vitamin D levels, a promotion of a healthier lifestyle with more outdoor activities and good nutrition is beneficial, but may not necessarily erase vitamin D deficiency. So recommendations regarding more sunlight or UVB exposure have the potential to increase the vitamin D concentrations in the serum, but also those recommendations are limited because of adverse effects related to skin damage and skin cancer. And then increasing the intake of natural foods containing vitamin D, such as fatty fish, can be considered a great step towards a healthier lifestyle, but it may not necessarily be enough to increase the serum vitamin D levels. So typically, a lot of times, a supplement may be necessary, and most multivitamins contain vitamin D, and the recommended dose is based on age. Vitamin D supplements are typically best absorbed when taken with foods containing fats. So calcium is the most abundant mineral in the body, and it is needed for adequate bone mineralization and maintenance of growing bone in children. Adequate calcium is also especially in adolescence, is important to promote optimal gains in bone mass and density, and low intakes can lead to increased risk of fractures, osteopenia, or reduced bone mass and osteoporosis. Calcium is also important in regulating cardiac, muscular, and nerve functions. Some factors that decrease the body's ability to use calcium and increase the risk for low calcium levels are listed on this slide. Preterm infants are at risk because of increased needs to support bone density, dairy avoidance, perhaps because of like a dairy allergy is a significant source. It's because dairy is a significant source of calcium, can also be a risk factor. Very high fiber diets, maybe high sodium diets, low vitamin D, laxative use, chronic laxative use, and diarrhea may also be risk factors. And adolescents and children age 9 and older with anorexia may be less likely to reach their optimal bone density and thus may be at a higher risk for osteoporosis and fractures throughout their life. So this table lists the recommended amount of calcium intake that changes with age. The body cannot make calcium, so it must be provided by the foods that we eat. Most children ages 1 to 8 can achieve the recommended dietary intake for calcium by eating these servings. So for children ages 1 to 8, typically we suggest 3 servings of dairy, which it could be from milk, cheese, or yogurt. And for adolescents from ages 9 to 18, we definitely suggest 4 servings of dairy to meet calcium needs. Non-dairy food sources and supplements are also alternatives as needed. And it's also important to keep in mind that to absorb calcium, our body also needs vitamin D. So this slide shows suggested portion sizes and calcium content in foods. Milk, yogurt, and cheese are really good sources of calcium, and other calcium sources include calcium-fortified juices, fortified ready-to-eat cereals, breads, fortified plant milk, substitutes such as soy milk, canned fish with soft edible bones such as sardines and salmon, some green leafy vegetables such as collards and turnip greens, kale, bok choy, and broccoli. And it's important to note that portion sizes, for each food can be different. So 1 cup of yogurt is considered a serving of dairy, but typically we find that individual cups of yogurt come in 4 to 6 ounce cups. And then 1 slice of hard cheese is equivalent to half a cup of milk, whereas 1 slice of processed cheese is equivalent to 1/3 of a cup of milk. So it's important to keep in mind what is 1 serving for one food can be different for another food. And then this slide is more of a snapshot of calcium content in various types of milks. It's important to note that this may vary slightly from brand to brand. And calcium, it's also, in general, calcium in cow's milk is the best absorbed. And calcium does not vary with the fat content in milk. So there is no difference in calcium content in full fat milk versus 2% milk versus 1%. And something to keep in mind is that cow's milk is high in protein and also has, it provides a substantial amount of protein in a child's diet if 2 to 3 servings are consumed daily. Soy milk and goat's milk are more similar in protein and nutrient composition as compared to cow's milk. And some plant-based milks are much lower in protein and calories and may not provide much from the nutrient perspective beyond the calcium. So this slide, I just wanted to kind of emphasize that it's only referencing the calcium content per serving and does not represent like the full nutrient profile of different types of milks. So in order to ensure that the body gets enough calcium, high calcium foods need to be consumed every day. And for some people, calcium supplements may be the best way to get the right amount of calcium. And there are different forms of calcium supplements, such as calcium carbonate and calcium citrate. And there's definitely times when you use one over the other. So calcium citrate is easily absorbable and doesn't really need stomach acid for absorption. So that may be a choice for maybe children who are on antacids. And if they have any issues with maybe some constipation or gassiness and other gastric issues with calcium carbonate. Calcium carbonate is by far the most common supplement. It is also less expensive, and has more calcium, elemental calcium in a single dose. So you may need to use less number of tablets per day when you're using calcium carbonate. So definitely pros and cons. And the other thing to also remember is that if a child is lactose intolerant, it's helpful to know that some calcium supplements may contain lactose. So I think that was it for the prevention and treatment of low calcium levels. And Kylie will now discuss about fortification of micronutrients in foods and micronutrient supplements.
Yep. All right, perfect. Yeah, thank you, Divya. So I know Divya talked a lot about supplementation and fortification specific to those micronutrients. I just wanted to kind of wrap up with talking about fortification in general, and then supplements that are available on the market, and some various different options that are out there and how to think through what to recommend. So first, when we think about fortification, there is a multitude of foods on the market that are fortified with a variety of vitamins and minerals. And like I said, Divya did a great job of going through some various different options. We see cereals, we see a multitude of milk options that are fortified. We'll see beverages. I've seen margarine. So many foods. And I think that's what makes it fun for us, is that we can really individualize the recommendations we provide, because we can look at that child's diet and say, okay, where can we add some fortified foods that would fit best for you? Divya did a great job of talking about the various milk options out there. The milk alternatives are not all the same. And if I'm looking to increase, calcium and vitamin D intake, and I feel okay with a milk alternative that isn't as high in protein, for one child, I might recommend that, versus another one, I might be more hesitant if we really need that cow's milk protein source for that child. So takes a lot of creativity, but this is a really great way to add micronutrients without necessarily having to do a supplement if you don't need to. But if we need to talk about supplements, sometimes they are needed. And I will say, my kind of preface to all of this is that all of these things that I'm going to share, really come from practice and things that we've learned and things that we've picked up from looking at a multitude of supplements that are available on the market when we get asked every day. We know that the supplement industry is not regulated. So we don't have that governing body like the FDA saying there are specific rules or you have to meet certain criteria. So it can get really hard and very confusing for families when they go and try and look for a supplement, because there's so much out there, and what one multivitamin might include in it, another one that looks identical may not have the same thing. But what we've learned is that, oftentimes a general multivitamin can be a really good source to meet some suspected micronutrient deficiencies or potential risk of developing a deficiency. We can help prevent that from occurring. And on the market, there are the hard chewable multivitamins, along with gummy multivitamins and liquid multivitamins. What we have found is that the chewable multivitamins, the hard kind of chalky chewable ones, seem to be the ones that hold the most variety of vitamins and minerals. You're going to get your biggest variety, the most out of one supplement. So, so oftentimes these can be a really nice go-to to get the most out of them. They also can crush really easily, and I can attest to that because I have done this at home. They crush beautifully. Just take the bottom of a cup, and you can mix them into food items. So for children that really you cannot get them to chew this, to take it, to eat it, but maybe we can mix it with some applesauce. It's a really nice option for that. They don't mix well with liquids, or at least with some of the brands that I've tried. There's still some things floating in there. It can feel a little gritty when you drink it. I have had families have success in doing that, but just be warned, it doesn't mix as nicely. What I really like about these chewable multivitamins, a majority of the time I can find them a multitude of options for families, and it contains iron in them. So if I'm really trying to encourage increased iron intake, I might lean more towards encouraging the hard chewable multivitamins, because they're going to taste better than just a plain iron supplement. Oftentimes they don't. Just plain iron, liquid iron supplement just tastes terrible. So this is a nice way with better taste to help get that iron in, along with the benefit of other micronutrients with it. Oftentimes with these, if you're going to see the iron a little bit higher, the calcium is going to be a little bit lower. Again, that same idea that we don't want that competition for absorption. They're sort of essentially wiping each other clean, or you're getting very little of either of them. So the next option is your gummy multivitamins, and these are everywhere. Everybody likes them. There's all kinds of flavors and varieties and price points, and I mean, you name it, it's probably in a gummy option. So that's a really big benefit for families, because they could meet the price point that they want. A lot of times kids really like gummies, so it might be an easier option for that child. There's also a lot of brands out there that have additional variety added in there, or additional quote benefits, if you will. So like this one you see on the screen, it's promoting that it has immune support. So it's always important to keep in mind, sort of flip that bottle over, look at the label, see what they mean when they say there's additional immune support. What are they actually adding to it to be able to make that claim? And do we feel it's appropriate for that child? Yeah, maybe the one kind of downside to these is that sometimes you have to take multiple of them every single day to meet the dosing amount. And then, and oftentimes they do have some added sugar. Again, if you're having one or two gummies, I'm not going to get too upset about that. But, if it's something where we have to be more considerate of that, it's something to keep in mind. And then liquid multivitamin options. So these can be really great in theory for a child that won't take a gummy, a child that won't take the hard chewables. Can we get them a liquid one, either syringe it directly into their mouth or add it to another liquid that's well accepted? But the downside is they're often, at least what we've seen, they're often more costly, and there's just not many out there, and it's hard to find them. So, it's not like you can just walk into the store, most of the time have, a whole aisle dedicated to these liquid multivitamins, and you can pick the one that you want and walk out of the store. Oftentimes we have to kind of guide the families towards looking on online sources to purchase them. And then even so, because there aren't many options, they may not even really be fully meeting the need for that child. And then the last is specific micronutrient supplements. And Divya did a great job of talking about when a supplement might be needed and what various dosing amounts are. Those are just coming from our DRIs. So that's a reference available to everybody. That's what we use. I find that this is an area that as a dietitian, we might lean back into the primary care provider for giving specifics on those supplement recommendations. We know what the DRIs are, but if we have a child that we're like, you're really showing a lot of physical symptoms of a deficiency, your diet is really proving to me that we're probably not getting the nutrients that we need. What always comes into question is, should we check a serum level and then do a repletion dose of that micronutrient? Then once our stores have returned to normal, then we'll take a maintenance dose from there. And because our scope does not allow us to write prescriptions, this tends to feel a little bit more prescriptive. So we really do like to lean on our primary care providers and just recommend to the family. I encourage you to talk to your primary care provider about obtaining a serum level, and then talk to them about what dosing amount you feel is appropriate for your child. All right, so we have a few minutes left. We wanted to run through some case studies for you guys, give you some kind of real life examples of what we might see if a child comes to see us for potential micronutrient deficiencies. So you can see this first one here is 5-year-old male is referred to come to nutrition clinic for the referrals for picky eating. So during the appointment, the grandma is saying, the child is really a meat and potatoes eater, likes lots of animal meats, starchy or potato-based foods, and snack foods. Grandparents frustrated because they can't get the child to eat any fruits or vegetables, and is concerned about the child's dairy intake, saying he won't drink milk, but he will eat cheese and yogurt. Some additional information: the child does go to full day, everyday kindergarten and eats the meals that the school provides. The child really doesn't have any significant medical history that might impact a potential for a micronutrient deficiency. And the child's growing appropriately. Their weight gain velocity is appropriate. Linear growth looks really good. BMI for age is normal. So there really aren't any growth concerns or history of growth concerns. So I'll give you maybe 30 seconds to kind of think about what are the potential micronutrients of concern and what recommendations would be provided. What do you think? All right, that was a little shorter than 30 seconds, but I want to get all three of them in. So I think the first thing to look at is, the grandparent did express concern about not getting enough dairy intake. So potential calcium and vitamin D deficiency. For that child, we know the goal, like Divya said, is 3 servings of dairy a day. So if we can find a way to help that child maybe increase their cheese and yogurt intake to meet the calcium and vitamin D needed, that would be, that's a really great place to start. I think this is another really good example of, could we possibly utilize one of those cow's milk alternative milks that are out there? If this kid is a meat and potatoes eater and they really like their animal meats, they might be getting enough protein in their diet that we're not too concerned that doing something like an oat milk or an almond milk, where the protein is not as high, would be a problem for this child. But we can really get a lot of good calcium and vitamin D, and the child might like the taste better. Another thing would be to look at just kind of a broad spectrum potential risk of deficiency of lots of vitamins and minerals, just because the child isn't eating very many fruits and vegetables. So we know our goal is a minimum of 5 servings of fruits and vegetables each day. And, yes, we want that child to eat more of those, but, you can't force them to eat more. So this might be a scenario where we would give recommendations on how to manage picky eating, strategies on how to help increase the acceptance of those fruits and vegetables, but also maybe recommend just a general multivitamin, more of as something to help fill in the gaps in that child's diet while they work on adding more fruits and vegetables, while they work towards accepting more of them. And a nice little perk, if the grandparents happen to purchase a multivitamin that also has some calcium and vitamin D, we've hit both areas of concern. All right, Divya, here is your case study. Or let's see. How are we doing on time? We have 2 more case studies, or should we stop for questions?
Let's go ahead and do one more case study.
Okay, Divya, I'm going to let you do the next one.
Thank you so much. Thank you, Kylie. All right. So for this second case study, we have a 11-year-old female who was interested in following a vegetarian diet for personal and ethical reasons. And the parents were never followed a vegetarian diet and were a bit apprehensive about how to support their child's choices while also maintaining adequate nutrition for growth. So they wanted to know what nutrients of concern or what nutrients they should be concerned about to be able to support good growth and development for their child. I'd like to preface it by saying that well-planned vegetarian meals and snacks can be nutritionally well-balanced. So during the consult, we discussed about the foods she was planning to include, if dairy and eggs would be included or excluded. And based on her goals, she did want to include eggs and dairy. So we discussed nutrients such as vitamin B12, zinc, D, calcium, and iron as certain nutrients that we want to be mindful of. So we did discuss about iron, calcium, and vitamin D through this presentation, but vitamin B12 is a water-soluble vitamin that is important for DNA synthesis, for protein synthesis, and is very important for nerve myelination. So when there's deficiency in B12, we see megaloblastic anemia, which is because there's impaired red blood cell synthesis. We also see impacts on neurological function, which could lead to peripheral neuropathy, dementia, poor cognitive performance, and depression. And vegetarian foods rich in vitamin B12 include dairy products, eggs, vitamin B12 fortified products such as cereals, breads, milk alternatives, and nutritional yeast. Zinc is another mineral. It's another micronutrient that is important for cellular metabolism, involved in in the activity of numerous enzymes, in enhancing immune function, protein synthesis, wound healing, and also in cell signaling and division. So some vegetarian sources of zinc include nuts, beans, whole grains, fortified cereals, and dairy products. So another thing that we discussed was protein, because protein it's not a micronutrient, but it is a nutrient that is important for growth and development. So we kind of also emphasized adding adequate sources of protein through the day to ensure optimal growth and development as well. So that was our, did I skip slides? I'm so sorry. That was mine. And then I'm giving it back to Kylie for our last case study.
Well, and maybe we'll save the last case study since we were able to go through 2 of them. And since we're getting close to the end of our time, we'll go on to questions. Here's our references if anyone would like. The NIH has a lot of good resources for specific micronutrients. If you're interested, it's wonderful. They have a lot of fact sheets. So we utilize those often, and I encourage you guys to check those out.
If you have any questions, feel free to unmute yourself and ask, or put them in the chat and I will read them aloud. Okay, well, if you have any questions, we're just going to go ahead and move right towards wrapping up for the day. You can always reach out to the emails on the screen or myself, and I'm happy to pass them along. So if you want to go ahead to the next slide. Thank you. Thank you again, Divya and Kylie, for facilitating such a great training today. And thank you all so much for coming. Please check your email to claim your CME and MOC credit. We do ask that all participants complete the short survey, even if they don't plan to claim any credit. This enables us to collect endpoint data to measure the rigor of our programming. Once you complete the survey, you will receive your certificate within 10 days, and I'll follow up with these directions via email for your reference. Next slide, please. If you have any questions or suggestions for future PMP programming, please call or email me, the program manager, at the contact information listed on the slide. And this concludes today's training session. Thank you all so much for your time and energy, and I hope to see you in another Ohio AAP training in the future.
Thank you.